Everyone appears to be here, even though we're a couple of minutes early. That's okay. We can start and fit more in that way. So welcome, everyone. Thanks for being here today. We are going to be hearing from the First Nations and Inuit Health Branch in the first hour of our meeting. And I'd like to, on behalf of the committee, welcome Sunny Perron, Senior Assistant Deputy Minister. Thank you for being here. Keith Kahn, ADM Regional Operations. Thank you. And Scott Dodge, Director General, Non-Insured Health Benefits. Thank you, Scott. Tom Wong, Executive Director, Office of Population and Public Health, and Leela Gillis, Director, Primary Healthcare Systems Division. Thank you all for making time for us today. I also will acknowledge that we're having our meeting today on unceded Algonquin territory, as we always acknowledge. And I am happy to give you 10 minutes to present your remarks, and you're free to divide those up among yourselves as you would like. Is there more than one speaker this morning?
There will be one.
Just one, okay. And I have these two cards. I'll hold up and sort of wave around a yellow card when we're at 9 minutes, and then the red card will be that we're at 10. And to please come right to your close then if you could, and that's in the interest of fairness so that everyone can get their questions and hear from you in a fair fashion. So thank you for that. And without further delay, let's please get started. You have the floor. Thank you.
Thank you. Mr. Chair, member of the committee, thank you for inviting the Health Canada First Nation Inuit Health Branch for this briefing on First Nation Inuit health programs. Health Canada is committed to ensuring that First Nations and Inuit communities and individuals receiving a range of health programs and services that are responsive to their needs. The overall objective is to improve health status. Comme vous le savez peut-être, les populations des Premières.
As you likely know, First Nations and Inuit peoples are facing significant health challenges. Compared to the rest of the Canadian population, they have a lower life expectancy, higher rates of chronic disease like diabetes, and higher transmissible diseases like tuberculosis, HIV, and they have a lower education rate and higher unemployment.
Legacies such as colonialism, the disconnection of culture, and intergenerational impact of Indian residential schools. The healthcare system for First Nation and Inuit is complex. Provinces and territory deliver hospital, physician, and public health programs to all Canadians, including First Nation and Inuit, but do not operate health system on reserve for most. In order to support First Nation and Inuit in reaching an overall level of health that is comparable with the other Canadian, Health Canada funds or provide a range of health programs and services in First Nation and Inuit communities. Within this context, Health Canada works with First Nations, Inuit, provincial and territorial partners to provide effective, sustainable, and culturally appropriate programs and services to improve health outcomes and support greater control of the health system by First Nation and Inuit. As part of this effort, Health Canada invests more than $2.5 billion annually in First Nation and Inuit health to supplement programs and services provided by provinces and territories. This includes over $840 million for primary health care and public health on reserve and $1 billion for health benefit. It also includes over $440 million this year for the British Columbia Tripartite Initiative, an innovative precedent-setting development in First Nation health, which took effect on October 2011 when BC First Nation, the province of British Columbia, and Health Canada signed the BC Tripartite Agreement on First Nation health governance. Spending also includes $240 million for health infrastructure support, which promotes First Nations and Inuit capacity to design, manage, and deliver their health programs and services while supporting health service innovation, integration, and partnership. There are 5 key elements funded by Health Canada to support First Nation Inuit health: health promotion and disease prevention program, public protection programs, primary care services, supplemental health benefit, and health infrastructure support. In the area of health promotion and disease prevention, Health Canada provides funding to support community-based health promotion and disease prevention program to support mental wellness, healthy child development, and healthy living. Programs and services related to mental health promotion, addiction support, suicide prevention, and counseling is funded under a range of programs such as the National Alcohol Addiction Program, Brighter Future, Building Healthy Community, and the National Aboriginal Youth Suicide Prevention Strategy. In the area of healthy child development, it supports children to have the best start in life through programs such as Aboriginal Head Start, Canada Prenatal Nutrition Program, and Maternal and Child Health. As part of the Indian Residential School Settlement Agreement, Health Canada also funds and provides health support services to former Indian residential school students and their family so they can safely address broad spectrum of wellness issues related to impact of these schools. In the area of health protection, the department delivers public health protection program including communicable disease control, monitoring of drinking water, wastewater, and environmental public health inspection of facility and housing on reserve. In this area, services are provided by a combination of Health Canada and First Nation employed worker. In the area of primary health care, Health Canada support access to primary health care services in 80 remote and isolated First Nation communities where access to provincial services is limited. Efforts are ongoing to enhance interprofessional team approach, increase the number of Health Canada nurses, including nurse practitioner, and to increase access to physician services. Health Canada deliver primary care in 52 First Nation community, while in the remaining location, these services are totally under the control of the First Nation. Through home and community care program, Health Canada support home care nursing, respite care, client assessment, and personal care home support in over 500 First Nation Inuit community. Most of these services are delivered by First Nation community employed health workers. As indicated before, Health Canada also provides supplemental health benefit. Health Canada support one of the largest health benefit program in this country and provide coverage for medically necessary goods and services to over 824,000 eligible First Nation and Inuit. NHB provide program coverage in different benefit area to supplement those that are usually available through province and territory or private insurer. This include coverage for prescription and over-the-counter drugs, dental services, medical transportation, medical supply and equipment, vision care, mental health counseling. The NHB program does not require co-payment or deductible and encourage health service provider to build the program directly so that clients do not face out-of-pocket expenses. The NHB program provides important coverage for medical transportation to healthcare services. Approximately 125,000 clients access medical transportation benefit in 2014 and 15, accounting for over 200,000 medical-related trips. Medical transportation coverage include emergency transportation, transportation to access medical care such as appointment with physician, hospital care, diagnostic tests, medical treatment, alcohol, solvent, drug abuse and detox treatment, traditional healer, vision and dental appointment, and mental health counseling. Specific to dental care, the NHB program provides eligible First Nation Inuit with coverage for dental, including diagnostic, preventive, restorative, endodontic, periodontal, removal prosthetic, oral surgery, and orthodontic services. Santé Canada fournit également du soutien.
Health Canada also provides health infrastructure support funding at 700 health establishments and nursing stations, which allows us to support First Nations in in health services accreditation, the adoption of cyber health technologies, human resources in Aboriginal health, and integration of health services. Health Canada is not acting alone. First Nations and Inuits are also taking on responsibility for many different levels to manage and offer a wide array of services funded by the federal government. The efforts to help First Nations and Inuit in their desire to influence, manage, or control health programs and services that affect them continue to be essential to improve the results and increase their access to the programs they need. This approach was motivated not only by a desire to ensure greater autonomy among First Nations and Inuits, but also to provide proof of better control that can improve the health results and make public health activities more efficient. Most community health programs were transferred to over 400 First Nations communities to various degrees. Some First Nations communities receive funding to design and offer health services autonomously, while others work with Health Canada to develop community health programs to model their programs and their health services. In some communities, Health Canada staff provides the service delivery jointly with local health teams. We have achieved significant progress in the integration of health services over the last 10 years. In many regions, we see examples where more than one doctor is present in communities, and the care continuum offered between the interior and exterior of reserves has improved thanks to collaboration agreements. These measures allow us to obtain better results and to implement care more based on the patient despite the complexity of the system. National organizations are consulted regularly, and the two main national associations responsible for representing First Nations and Inuit are present at the discussion tables with our directorate. Tripartite tables exist in most regions to hold official discussions with provincial partners and territorial partners and First Nations partners as well to promote shared priorities. I would like to speak briefly about some of the priorities that concern us.
To experience complex mental health and substance abuse issues. And we have been working with the Assembly of First Nation over the last few years to develop the First Nation Mental Wellness Continuum Framework. This framework was endorsed and released by the Assembly of First Nation in January 2015, and implementation is underway with First Nation partners at the regional and national level. Health Canada will also participate in the whole-of-government approach to address call for action of the Truth and Reconciliation Commission. We are also working jointly with the Assembly of First Nation on a joint review of the non-insured health benefit program. This is a benefit-by-benefit review with the FN to discuss improvement of the health programs and services. I want to thank this committee to give us an opportunity to be with you today, and we will be pleased to answer your question.
Merci beaucoup, Monsieur Perron. Thank you very much, and to your colleagues as well. I know that 10 minutes goes fast, and if there's more that you want to share with us today, we'll find a way to fit them into the questions as they come up. So we'll move into a round of 7-minute questions, and the first question is coming from Michael McLeod, please.
Thank you, Mr. Chairman, and thank you to you all for coming to present to us today. This is an area that I think concerns all of us throughout Canada, the area of healthcare. I'm from the Northwest Territories, and we certainly have our share of issues across the north. We are a large area with 33 communities and struggling to have the services provided in our communities. It's very rare that you'll see a doctor twice in the communities. And even the nurses are, for the most part, all locums, which come in for a short stint and then leave. 70% of our government of Northwest Territories budget is spent in the area of the social envelope, and a lot of it is being spent on health. And when it comes to our Aboriginal population, we have the First Nations people who are covered through non-insured health benefits, and we have the Métis people who are covered through a program funded by the government of Northwest Territories. So they are carrying a huge burden of costs, and it's really causing a lot of challenges for them to provide health care for Aboriginal peoples. I'm very curious as to how the non-insured health benefits is calculated. In Northwest Territories, there is a set amount of money that is provided on an annual basis, and I'm not sure if it has increased over time, but I know that the government is spending roughly 3 times what is provided because the federal government hasn't up to now been willing to cover the cost, the actual costs. There seems to be a formula that is used, not really measuring the health needs of the First Nations people. Okay, so my first question is in that area regarding the needs, the real needs for Aboriginal peoples in the Northwest Territories. We don't have treatment centers either, so addictions is an issue, health is an issue, offloading to the territorial government is an issue. So maybe if you could just talk about that a little bit, and then I'll ask my next question.
Thank you for the question. Maybe a little bit of context. Around 20 years ago, there was an agreement between the federal government and the territorial government about the transfer of primary health care services responsibility to the Northwest Territory government. So all the Health Canada First Nations Health Branch doesn't provide community-based health services in this territory. We do have an agreement with the territorial government to provide them over a multi-year agreement funding for public health programming, for example, home care services, maternal and child health, these kind of programs. We have a master agreement with the territorial government to fund these programs, and some of these resources flow directly to the community from the territorial government. But the main responsibility of the territorial government for primary care with ensure health services in the territory is with the territorial government. It's not with Health Canada. Where we also intervene is that First Nation or Inuit people living in NWT are covered by the non-insured health benefit program. So for medication, dental care, medical supply and equipment, vision care, these benefits are totally administered by Health Canada and funded by Health Canada. So we pay the full cost of these benefits for the client living in Northwest Territory, like anywhere in Canada. For medical transportation, we work with the territorial government to pay our share of the transportation cost for clients, First Nation client. You referred to the Métis. Métis are not eligible client under non-insured health benefit. The policy for this program is for Inuit and First Nation at this time. We also have a territorial funding arrangement to supplement funding to territorial government to assist with cost of the health system. And in there is an envelope, but I cannot tell you exactly the amount. I don't remember, sorry, about medical transportation. The territorial government is receiving an additional envelope to support the cost of medical transportation in the territory, because it's known that the cost of transportation there to have client accessing the needed care is pretty high. So there was, in addition to the main transfer, there is that envelope that is provided annually to the territorial government to assist with the cost of medical transportation.
Yeah. Thank you, Mr. Chairman. I'm quite familiar with the arrangement with territorial government. I spent 12 years in cabinet with the government of Northwest Territories, and maybe we can get into the specifics. And I'm certainly familiar that the Métis are not included. The government of Northwest Territories has taken that responsibility on themselves. So I have two questions, given the short period of time. Given the results of the Supreme Court ruling on the Daniels case now, would you be able to give us some insight of what the plans for including the Métis in the non-insured health benefits? And the second question is regarding the Truth and Reconciliation's call to action. That it states that they should provide a sustainable funding for existing and new Aboriginal healing centres to address physical, mental, and emotional, spiritual harms caused by residential schools, and ensure that funding of healing centres in Nunavut and NWT is a priority. So I'm very eager to learn what that means and what that's going to translate to.
Thank you for the question. So regarding the coverage for Métis, at this time, the policy coverage we have for the program in Health Canada is about providing service for First Nation and Inuit. So since the court decision, there has not been a change in terms of the eligibility of these programs. The responsibility for providing health care remain with the territorial government or the province and territory in general for the rest of the population. As for the TRC call for action, there is 7 recommendations that are directly related to health care or health services in there. We are in the process, we are working with the Assembly of First Nation, the Inuit Terrific Kanatami, and also the Métis National Council to engage them to support and get their views in the context of the Health to Core process. We do expect that during that process we will be able to get the perspective of these 3 groups about how we implement these 7 recommendations that are directly related to healthcare. Some of them, as you probably know, are in the range of responsibility of the province and territory. So we do expect that this process will give an opportunity to learn about how we could best implement these measures. Thank you.
Thank you. With that question and others, I mean, there's a lot of subject matter here. If you feel like you would like to provide any further information in writing, we happily receive that as well. Thank you. The next question comes from Kathy McLeod, please.
Great. Thank you so much for joining us today. And I want to start, and I'm sure that you're aware of some testimony recently by a doctor that was here at committee, and also the APTN has been did a bit of a series in terms of the non-insured health benefits. And you know what struck me, if you look at perhaps the federal service plan, it's pretty seamless. The orthodontic work is the dentist might flip a picture in, and the approval comes very quickly. To my knowledge, I don't know of any declines in terms of orthodontic services for people under, let's say the public sector plan. It seems like there are plans out there that are seamless, that they are very burdensome-free in terms of, the paperwork, the process. And so in comparison to at least the stories we've heard, that is an issue. So I guess you talked about working with the AFN in a review of non-insured health benefits. Are you looking at your systems and processes in terms of the more seamless provision of service that is the norm? I guess that's sort of the first question. The second part about that, and then I hope to get some in terms of primary care, is we heard about, the formulary is very restricted. So I would like to know if your formulary compares to what is routinely available, for example, in the province of Ontario. So those would be my first two.
Thank you for the question. I will start on the non-insured health benefit joint review process and probably ask my colleague Scott Doge
And if you could let me know when I have 2
more
minutes
detail.
left for primary care. Thanks.
The joint review, yes, will allow to go benefit by benefit and look at the irritant in the system. Things we know is that we are running a plan that have coverage in 13 jurisdictions across the country, and most of the health system is driven by province and territory considerations. So formularies are different, program coverage is different, physician practice in terms of prescribing are different. So we have to learn about where are the irritants to be able to fix that.
Can I just interject,
Yeah,
though?
for sure.
So the Sun Life covers federal government employees across the country. They don't worry about all that.
Yeah, and this is, I think, during the review process, we will have to examine this with the FN because the design of this program is pretty important. I mentioned earlier, there is no co-payment, no deductible. I should have mentioned there is no maximum amount either. So we do have clients that receive like hundreds of thousands of dollar coverage annually because their needs is for that amount. However, in order to balance the plans that have no limit like that will have some criteria for coverage, which is medically necessary. And in the area, for example, on drugs where we ask for predetermination, it's mostly around drugs that are have an addiction issue built in that needs to be controlled. So this program has been recognized as one of the most sophisticated in terms of preventing overprescribing. But it does bring some rules, and this is what we want to discuss with the EFN. On the dental care, you referred to the public service employee plan. Again, there is a maximum. So if you go above this maximum in a given year, you're on your own. Dental orthodontic treatment, you have a maximum amount, I think it's around $2,000, and then the rest of the bill is with the family to pay for. In the case of non-insured health benefit, if the client receives coverage, we will pay in full the full cost. There won't be a copayment, there won't be a deductible. However, the medically necessary criteria will be applied. So some of the opportunity to get orthodontic treatment or even dental treatment that is not medically necessary will not be covered like it will be covered under a private plan that only cover a portion of the cost. It's a choice. It's a choice. Public plans usually will have more element of predetermination in to be able to cover more and offer more coverage for the clients. In terms of administrative process, maybe Scott can give us a sense in terms of the percentage of claims that receive approval without any prior approval or predetermination is pretty important.
So, sure, and maybe I'll tackle your comparability question after that. About 99% of pharmacy claims are ultimately approved through NIHB, and the majority of those claims, over 90%, are approved on the spot through our electronic claims processing system. There's no out-of-pocket for the client. The provider is subsequently reimbursed for that. There are some claims for which we do require further information, as Sunny mentioned. Many of those drugs are drugs that are subject to abuse and are part of something we call our prescription drug abuse strategy. So we do seek further information through our drug exception center here sorry.
I have 2 minutes left,
Okay.
and I have to get to primary care.
Okay, sorry.
So we heard you run 52 of the primary care services across Canada. My first question is in every one of those settings, is the capacity for internet such that there is good opportunity for telemedicine? The second is, we hear about sort of the lack of resources services, having run a number of rural community centers. I know that communities have huge challenges in terms of physician service, nurse practitioner, mental health counselor. So I appreciate the recruitment challenges. Do you run those at a comparable level to a non-Indigenous remote community in terms of the service level? Have you studied it? Can you table any studies? So I guess that'll use the minute.
Thank you. I will start in terms of the objective is to run at the same standard. There is some challenge in terms of geography and distance and recruitment of nurses, but also availability of physician services that is provided by the province. We have been over the last year able to increase the physician presence in the community, and when the physicians are not present, the nurses have access on call to a physician to get some direction in terms of service. Maybe Leila, you want to comment on the level of care and the recent assessment we have performed following the 2015 OAG report.
Certainly, we're certainly challenged with geographic location, and we do have models that are similar to other geographic locations. However, we are about to do a comparative or descriptive analysis where there are comparable locations with provincial services. However, we do have and have increased nurse practitioners in many of our nursing stations, and part of our analysis of each nursing stations and their essential services are the plans of enhancing skill mix, collaborative practice arrangements for physician coverage, but also to increase the number of nurse practitioners in our nursing teams within the nursing station.
Thanks. Yeah, that's it for time. The next question is coming from Charlie Angus. Please, Charlie.
Thank you very much for being here, and Mr. Khan, it's nice to see you here. We're both in our suits today. The last time we were in Attawapiskat, we were in our rubber boots. I only have 7 minutes, and I have so many questions. I wish we could do this all day, but I only have 7 minutes, so I don't want to sound rude, but I got a bunch of short questions and hopefully short answers. Can you confirm that the Conservative government set aside money to implement Jordan's principle between 2008 and 2012?
There was actually the ACTA fund that was created at the time, yes.
Okay. So is that fund, I didn't see it in this budget, so is that fund there now to implement Jordan's principle?
The fund has been eliminated in the context of the Deficit Reduction Action Plan.
Okay. So today is a deadline for implementing Jordan's principle, so there's no fund to respond to the Human Rights Tribunal, but there was under the Conservatives?
I would say I cannot really answer your question the way you're presenting it. Today
Okay.
is the
So
date
today
for
is the deadline
to answer.
Yeah.
We have taken some measures in order to be in a position to acknowledge the decision of the
acknowledge the
tribunal.
decision, okay.
Our staff have been directed to move away from the old definition because the tribunal have been really clear about what should be the approach going forward.
But there's no fund set aside to implement?
The envelope that was set aside up to 2012 is not there.
It's not there,
anymore.
okay. So looking at the Human Rights Tribunal ruling, a lot of the evidence is child welfare, but a lot of it was your department. And so looking at the evidence that was put forward by your own officials, there's some pretty disturbing statements. Tab 78 on gaps in service delivery to First Nation children says that the denial of prescriptions that have been ordered by pediatricians is common. On what basis? Like, who would make a decision to deny a child prescription if a doctor's ordered it?
So I cannot really comment on the case specific that was behind this and the evidence that the person or the witness that have brought this to the attention of the tribunal. What I can probably ask is Scott to give us a sense of what is our rate of approval and the instances where
these aren't individual cases. This is systemic. That's what they're saying. These are systemic issues that children are routinely being denied prescriptions that have been ordered by pediatricians. Tab 302 that was supplied by Health Canada to the Human Rights Tribunal says that if a child with multiple disabilities requires a wheelchair, lift device, or tracking device, they're only allowed one of those items. And if they opt for a wheelchair, they don't get a motorized wheelchair. It has to be an adult pushchair. So is that like policy, or is that what the bureaucrat decides?
the level of coverage and the criteria for coverage depend on the nature of the handicaps faced by the child. So each case is assessed case by case. if the service or the supply, the medical equipment is required, it will be paid in full by the program.
Okay.
There was some issue raised in the tribunal, for example, related to medical beds.
Yep.
We have resolved that issue.
Okay. Because that was the one where the child was going to die, and Health Canada said absolutely not.
Yeah.
And the doctor paid out of his pocket. So I want to ask, because it's come up with the testimony from our hearings, some very disturbing hearings, and one of the allegations that's come forward is that Health Canada is telling doctors only to use one catheter bag a day, which means they have to reuse them, which the doctors, I'm not a doctor, I don't know much about this, says they cause recurrent infections, kidney disease. So is that a decision made by a doctor at your office, or is that just someone crunching pennies here?
I'm not aware of this, any directive about this. Scott, I don't know if under medical supply and equipment, if there is such a directive. I've never
Okay.
seen that, and I've been in this program for a number of
Okay,
years.
so, I mean, that's a pretty serious allegation. Dr. Curlew says that children are dying from childhood illnesses that are known elsewhere, such as rheumatic fever, because they're being prescribed Tylenol. So when a child dies at a nurse's station from a lack of medical supplies, are there investigations done to find out why that child died?
Yes, when there is incident, it's not only in case of deaths. When there is incident, there is a protocol to review the incident, to review the charts, and involve external parties if needed in this review. The objective is to understand the cause and if there is any responsibility of the health provider in this context, and also to improve the process.
Okay, because Dr. Curlew stated yesterday in the newspaper that he's concerned about his the Hippocratic oath as a doctor under non-insured health benefits, because he says, I know the system is actually harming people. So I would think you'd want to look into that. But I'm running out of time here. I wanted to know about, the department states that Health Canada spent $300 million on mental wellness last year. This year's RPP state $270 million. So does that mean a $30 million drop in mental health programs, and what program would that come from?
No, there is no reduction of spending in mental health. This is probably related to programs that are being renewed and will appear when we get to supplementary estimate process.
Okay, so I'm told there's only 10 mental wellness teams for Indigenous mental health teams across the country. First Nations are saying they need 80. So can you confirm that there are 10 mental wellness teams?
Based on the mental wellness continuum framework, we have started to invest in a couple of years ago into building mental wellness team. This is a model that has proven to be effective.
Yeah.
At this time, there is 10 or 11, Tom? 10 that are being funded throughout the country. But
So-
this is in addition to the local mental health services.
Okay, so we've been told there's only $350,000 put into that First Nation mental wellness continuum framework. Is that true?
No, and we are spending, we have spent last year around $300 million in mental
No, I know,
health.
but within that framework, I've been told up to date there's only been $350,000 put into that. Is that?
I cannot comment. So part of the framework is also to manage the funding that is already in place in these programs, to realign them under the framework. This was the intent of that framework, but also to inform future investment.
Okay. Okay, I guess finally then, going back to these issues that we're seeing from the doctors, so the testimony that was raised at our committee about children who are left at a nurse's station for 13 hours crying in pain because they don't have painkillers, or children starting to suffocate because they don't have Ventolin, that to me is pretty disturbing. It would sound to me like if that's a common practice, wouldn't that be kind of like institutional malpractice? How is that allowed to happen in a medical system in 2016?
We're
Situation that-
right out of time there, I'm afraid. If you can maybe get the answer into another question if it's appropriate. Thanks. The next question is coming from Remy Massé, please.
Alors, bonjour, j'aimerais...
Good afternoon. I'd like to thank you for attending this committee. It's really appreciated, and I know that your respective teams worked very hard so that you could participate this afternoon, so I'd like to thank them as well. One first question. In 2013-2014, the annual budget of the non-insured health program was about $1 billion, which was a 7% drop from the previous year. I would like to hear you on the reasons why there was this budget drop, given that it seems that the needs are growing every year. I'd like to hear you on that. Thank you. In fact, there is a constant increase in this program. I don't have the numbers here to confirm it, but with the transfer of health responsibilities from the First Nations Health Authority in British Columbia, the funding for the program and for the various program sectors was under one envelope of $140 million, which was fully transferred to that agency. That means that the programs that you're seeing in the estimates or in the annual report have changed because there are some responsibilities that were set into a different independent envelope for BC. But I can confirm that annually the health program is growing by 5%. And spending is continuing to grow currently. So there are no cuts, if that was the basis of your question. I would like to hear your thoughts on the main issues that you're facing in service delivery. What are the three main issues you're facing, and what are the solutions that you have identified to improve non-insured health services? First, thank you. One of the main issues is the availability of resources in nursing care, whether it's in remote or rural regions. Recruitment and retention is a challenge. The workload is very significant, which means it's hard to keep people in these positions for a long time. We have people who do this for their careers, but attracting new workers is hard, and we need experienced workers because the workload is large, and they need to offer a wide array of services. The support of these workers and their connection to the rest of the health network. These are federal services surrounded by provincial services. There can be integration problems. Yes, it remains a major challenge. If the doctor comes from a provincial program, you need to ensure that things are cohesive, and that is why the model I refer to in BC is important. It allows us to put all responsibilities and resources under one organization that is controlled by First Nations. So jurisdictional problems, service integration problems, collaboration program problems among different service delivery. The First Nations have full control of their services, and there is a commitment by the provinces to work with the First Nations, and there is a commitment by the federal government to act as a partner on the issues that the system is facing. So the integration of services is perhaps the second, and the third major one is mental health. The previous MP referred to the situation. It is a challenge. There are growing needs, and these needs are from historical situations. There are also new needs, for example, related to prescription drug abuse. All of these are vulnerable populations in many cases, and it becomes an issue for health services because it adds additional pressure to health services. It's creating a need where there wasn't one before. So we need to provide additional services, and some programs allow us to do so. The work with First Nations, the work with Inuit to define strategies is very important. And we need to do this in a culturally responsible perspective. We need to rebuild things that were destroyed under the colonization model that was in place for over a century, and we need to change this to bring culture back to the heart of any intervention, and we need to respect First Nations. But it's being done little by little, and we need to strengthen abilities in communities, and that's a challenge. Some communities have very sophisticated plans, and they can organize themselves to change programs and develop them to meet their own needs, but they need to develop the human resources and attract workers who want to stay in these areas. So these are very important situations. We've made excellent progress, and what we see in the media is often the challenges, and we definitely need to focus on that. But there are also places where extraordinary progress has been made, and there has been great creativity where First Nations really properly control their health services, and they developed models that are very interesting and promising. Do I still have time? Very quickly, in the Auditor General's audit, in his 2015 report, a number of issues were raised. You spoke about communities that have federal government responders and domains of responsibility. What did the Auditor General mean by this, and what are the solutions that were explored to resolve this problem? The main challenge is to ensure that we can work with national programs in provincial contexts, where in some provinces, there are provinces that offer services to on-reserve First Nations. There are other provinces where there are no services. They're excluded from the provincial system. And there are some provinces where they provide primary health care to First Nations communities. So our programs must be adapted to the reality of each of the provinces. And that's why we have this trilateral table to try to tailor the service and do integration and discuss problems with First Nations communities and also with provincial and territorial partners. We are making progress, but the progress is gradual on each of these subjects. We need to find models that work. In Ontario, for example, we have a bilateral agreement with the province and First Nations, and we're making progress on shared responsibilities. The same thing in the Atlantic and in the Western provinces. So that can solve integration problems. Thank you.
We're moving now to the 5-minute questions, and the first question is coming from Todd Doherty, please.
Thank you, Mr. Chair, and thank you to our guests today. Mr. Perron, can you tell me, I just want to deal with the emergencies that we have in Losh and Attawapiskat. Why the delay in getting the critical help that they need to those communities? Indeed, Losh is still waiting for some critical support, even to this point today. Attawapiskat, our honourable colleague, was taking it easy on the panel today, I think, because I think clearly he could have had an opportunity to ask these questions. But, you know, we have a crisis. We've all talked about it. There's been considerable amount of media attention. This is not new, and these are crises that we're seeing in First Nations communities, not just in these two that we've mentioned. But specifically, why the delay in getting that critical help to these communities?
For the question, I'm going to share my time with my colleague Keith here that can talk about the situation in Attawapiskat because he just visited the community and is quite familiar with the file. I will talk about the Lalosh situation. There is a reserve nearby, which is Clearwater River Dini First Nation. This is where Health Canada First Nation and Health Branch mandate is. So we have worked with the community, with the Middle Lake Tribal Council. They have a mental wellness team to provide additional support to the First Nation at Dini community. And 2 weeks ago, I had my regional executive reaching the chief to make sure that what we have done and the service that they were provided by the Middle Lake Tribal Council was satisfactory, and we got signal that things were working well. We are working with the province. If you're referring to the La Loche community, this is not a place where our mandate is operating. We work on reserve in the First Nation Dini community, and I would say for that portion, the assessment is that we have been responsive. Now we are looking at the long-term needs. So what this community needs. Fortunately, the Middle Lake Tribal Council, which is the authority that provides service to the First Nation in this area, has one mental wellness team that we were referring to earlier today. And this has been the instrument that have been used to leverage some capacity. There was also help from other First Nation organizations in Saskatchewan that were directed toward the community to assist with that tragic situation. Maybe I will ask Keith to talk a little bit about the situation in Attawapiskat.
Sure. Thank you for the question. So in terms of Attawapiskat, we did have a sense working through our communications with the chief and council and the community members that there was issues percolating. So we actually were able to deploy some mental health resources through the Anishinaabe Nation organization, who has a crisis response. So even before the declaration, we had some surge capacity deployed to the community with our assistance. And then once the declaration of emergency was made, there was about 2 days after, or 2.5 days, there was a SWAT team, actually a crisis response team that was deployed to the community through our NAN partnership of mental health crisis counselors, youth coordinator, So again, this is a crisis kind of environment, so there's a bit of a rotation. So that, I think we need to look at, as Chief had said, more medium and long-term work in terms of what is the transition from crisis to stability to mental health supports for youth and the community at large. So I think we were responsive. We have now our provincial partners. I won't speak for them, but I know I can say that they're presently and physically. That's the emergency medical assistance team who are deployed, I think, a week after the call, and Minister Hoskins was responsive in terms of making that happen. So they're continuing. They have nurse practitioners, mental health workers, psychologists that were hired through NAN. So that are in and out in rotation, and there's people that need some respite care, of course, in terms of the volumes of work and the intensity of the work that's in the community. So we were looking at a more sustainable model in terms of medium-term planning. We will be deploying some federal presence at an executive level this week to look at the more medium and long-term planning processes. And
I really appreciate your comments, but I think if you asked our honourable colleagues from both La Loche and Timmins James Bay, that they might have a differing opinion on what is really happening and the critical need for medium to long term. But there are challenges that we face today, that the suicide epidemic is still taking place. We have children that are still choosing to take that avenue rather than or seeing that that's the only way out. I'm going to switch. Hopefully my colleague from Timmins James Bay will follow up on that. Sorry. Okay. Thank you for your time.
Okay, thanks. Next question is from Don Resnack.
Thank you for all being here today. I've worked a little bit in health in northern Manitoba, and I'm going to forget the year, but I think it was, if you know, the 64 agreement, where there was a sharing of, not a sharing, a divvying up. We often called it doctors in the middle of the north with a bottle of rye deciding who was going to do what for which community. And some communities had, the Norway House, for example, had a federal hospital. I don't know if they still have the federal hospital. The provincial nursing stations were providing care for communities, I believe Easterville. It was many years ago, so my memory fails me. But it was an agreement that probably worked at the time, but perhaps doesn't work today. I don't know the status of the agreement. I know I was in discussions with both Health Canada. I was with Manitoba Health at the time, and the provincial government and the First Nations to come up with something better. And I know that's what needs to happen across the country. There's models, successful models that work and that provide good care, continuous care for people in First Nation communities and Indigenous communities across the country. I'm going to shift a little bit because I wanted to clarify a remark that my friend Mr. Angus made when he asked you a question about the fund set up by the previous government regarding Jordan's principle. And you started to answer the question saying that the fund was no longer there, but it was removed as a result of deficit cutbacks. And that was in what year?
2012.
Okay, so it was put in by the previous government and cut by the previous government, just to make that clear, because I like the facts, and I think the facts are important.
I think the fund has been created in 2008.
2008, but it was cut back in 2012.
Yes.
Okay. Another thing, the Auditor General's, I'm going to switch gears again on you, and I know I only have 5 minutes, but the Auditor General's 2015 audit found that only 1 in 45 nurses examined had completed all 5 of Health Canada's mandatory training courses. The audit recommended that Canada should ensure that its nurses working in remote First Nation communities successfully complete the mandatory training courses specified by the department. In its response to the recommendation, Health Canada notes that significant vacancies and turnover rates for nurses has made it a challenge to meet the training course requirements. Why are the mandatory training courses not provided prior to the assignment of nurses to First Nation communities?
Excellent question. Since the OAG report, we have made some progress, and Leila can give you some of the progress for each of the course. These are the 5 mandatory courses that were identified by Health Canada in order to make sure we prepare the nurse properly for the work that they will have to perform in remote and isolated community. The plan is to train nurse when they come in, and this is what we do before we send nurse in the field. There is a week or two of intensive training, onboarding to prepare them for the work, to make sure that they meet the mandatory requirement. One of the challenge and the relationship with vacancy is the renewal of the training. After 2 years, the nurse needs to go through the training for recertification. And when we were facing, and we are still facing, a certain level of vacancy in some area, it's difficult to take out a nurse in a need where there's a need for having nurses and send them for 2 weeks in training at the time. So this is where we got behind in terms of training. Our vacancy rate in the last 2 years went from around 35% down to 16% now. So we have made some progress, and all these nurses that are coming in needs to be trained. The fact that they work part-time or full-time are trained the same way. Maybe, Leila, you can give us some results in terms of training compliance for each of the programs.
Sure. Of the 5, we do have 5 mandatory courses that are identified, and they are provided as part of the onboarding program. It is the recertification that affects, I think, statistics in regards. We have improved the rates to 55% of all nurses who are working in the field, and our goal by the end of this fiscal year is still 100%. That is the goal that we have set for our employees. So I don't know if you want it specifically. The courses are advanced cardiac life support, pediatric advanced life support, international trauma life support, the controlled drugs and substances to handle controlled substances, as well as immunization. So it's the combination of all of those being active and active certifications that we are monitoring with all employees.
Okay, thank you. Thanks very much. The next question from Kevin Sorensen, please. Yeah.
Thank you. I'm not a regular on this committee, but I certainly appreciated your testimony today. I'm a member of Parliament from Alberta, and right now, obviously, we are watching very closely our north in Alberta. We're watching the Fort McMurray area. We've talked about emergencies in Attawapiskat. That's an obvious, massive issue and emergency that we need to deal with, also in the Losh. I'm just wondering how Health Canada is involved in the evacuation, if they are. I was, in previous years when L'Orange had the fires in northern Saskatchewan, I was at an evacuation site in Saskatoon. And I was impressed with the way it was set up. I think it was Health Canada that was there, diagnosing, looking at people, especially Aboriginal First Nation people, making certain that they were in good health and checking for other health issues as well. Can you maybe just quickly, are you involved in this Alberta evacuation?
We are working with partners, including First Nation, on this. This is a very tragic situation, and we have responsibility in that context. As soon as First Nation living on reserve are impacted, or we have role. Like I mentioned initially, we have role in terms of providing health benefit services. We have role in providing health protection services. We have role in providing nursing services. So our team in Alberta region have been working with Alberta Health and the Emergency Authority to try to organize service. We have provided some surge capacity to our regional office with additional nurses. We have reached out to other regions to bring an additional environmental health officer. We have also organized service for people that have to move from their place of living. For example, when you leave your community, you go into a different place, you may have left your medication behind. So Scott team have issued communication to pharmacists, communication to client to facilitate them to refill their drugs, assistance. We have sent more staff there. So in various fashion, we are working with First Nation. We are working with the provincial partners, the federal partners, to respond and support First Nation community that are affected by that. Environmental health issue is a challenge, so we will have our EHO inspecting if there is concern from First Nation to make sure that the place of living is safe. So we are doing these things. In addition, sorry, there was one thing I wanted to mention. It's just slipping out of my mind. It's very important in terms of a response. Keith, maybe. I said I need to mention that to the committee, and now I'm just losing. I'm losing the point.
Keith,
you cannot
can you
read
read
my
his
mind.
Can't get it through osmosis.
Yeah, no, not today.
All right.
Oh, sorry.
Go ahead.
Fort McMurray, for several First Nation community, is a location where people get their services. So they leave their community, go to Fort McMurray to see a doctor, to go to the hospital to get the needed services. So one thing that in the first few hours after at the beginning of this crisis we did is to start to work with all these First Nation community to redirect clients toward other point of services. So they will still be able to see a physician. They will still be able to see get access to care, but not in Fort McMurray, because we manage medical transportation, so there is some logistic involved. And this was probably one of the first tasks that our Alberta Regional Office started to work on, is to redirect client toward other points of services.
All right. Mr. Rusnick took a little of my question, because the Auditor General's report in 2015 did speak of the need for nurses. My wife's a nurse, my daughter's a nurse, and we know the good work that they do. He also mentioned about this one fund that was cut in 2012 by the former government, but the estimates show that there was a 5% increase in funding even through those years. There was added funding, was there not?
This is for the 5% increase is around the non-insured health benefit program, which is the drug, the dental care, medical supply, vision care. So there's a 5% escalator on that budget that is around $1 billion size.
So there was
but there is not an increase. There is not an escalator on all programs. Some programs have no escalator. This one has a 5% escalator.
So some programs are, as they are deemed not needed, they may be cut, they may be held the same. Other programs, there is an increase in funding. Is that correct?
Exactly.
Exactly. So just so we like the facts, we like them all on the table. We all like those facts laid out. Could you also just perhaps give us the current proportion of Health Canada nurses who've completed the mandatory? I know he asked the question on mandatory, but is it back where it should be?
10 seconds, I'm afraid.
Sure, and as I indicated, it's 55% of all of the nurses have met mandatory, and our goal is 100%.
And did you have a timeline to get it to 100%? Are you on time?
Our goal is by the end of this fiscal year that it will be 100%.
Thank you, and thank you, Chair.
By all means. Thank you. Okay, thank you. That'll be good. We appreciate that. The final question that we have time for is Mike Bosio, please. Mike.
Thank you, Chair, and thank you all once again for being here today and providing this very valuable information. As Charlie said, so many questions. What percent of Health Canada employees are Indigenous?
This is an interesting question. I cannot really answer for Health Canada as a whole, but in our branch.
Sorry, in that branch.
In that branch, there is 2,400 employees across the country. I think our rate is around 26% right now. We have an objective to reach in the next 4 years around 30%.
What about in the executive branch of your department?
I don't have these. I don't have this ratio. We have an Aboriginal Management Development Program to increase the number of Indigenous people in the executive branch. We have a number.
What percent of nurses and doctors are of Indigenous background?
I don't.
Currently, it's 24% of nurses are self-identified as Indigenous.
And I assume there is a very specific dedication of resources towards recruitment and training of Indigenous nurses to work in their communities?
I'll let you answer that question, but I just want to supplement Mr. Perron's response on you asked a question on the executives. I've known that there's 5 senior executives, Indigenous executives in the branch.
In the branch?
Safely say that.
Of how many?
I'd say
probably 20.
On our branch executive?
20.
Yeah, about 20.
Okay. Sorry.
Go
yes. Is there a focused program dedicated to recruitment and training of Indigenous nurses and health staff?
It is not a specific. We actually will take any and all nurses within the organization, so it's a very broad recruitment and retention. We do work with the Canadian Indigenous Nurses Association in the promotion of nursing or Aboriginal or Indigenous individuals to enter into nursing regardless of the employer.
But from an educational standpoint, is there any program that's specific towards trying to steer Indigenous youth towards either health programs or skills trades, or in your instance on the health side?
Yeah, there is a number of specialized program, but I would say in health sector, what happened is several university or college have identified this as one of the segment of the population that they want to bring in. And we have a program, which is the Health Human Resources Program, that provide $3 million a year in bursary through the Inspire Foundation.
So part of the program, sorry, I hate to cut you off, but part of the problem though with that is the fact that you take them out of their communities and they become integrated into other communities, or they don't go back. I'm just wondering, given the technology that's available today to deliver programs online, are there online programs that can be utilized to train nurses? Yes, you need to bring them to the centers in order to do practicum, but most of the training can actually occur within their own communities today.
I would say that even for the mandatory training that my colleague Liela was talking about, we have to bring them out to do the practice side. And nursing is a practice-oriented learning process, so technology can be used for some theory, but it's usually done in university and colleges. So we are using telehealth for training, but it's more like specific time-limited training activity to update their skills on some subject.
But given where things are today with MOOCs and other online courses, there's certainly that. I think that we need to start thinking outside the box in order to start trying to deliver programs and get Indigenous people trained. How is the funding for health determined in communities? Is it by need, per capita, by comparison to provincial standards? How is that derived?
Most communities have a community health plan, and they have been funded to develop that. The basic is population size, and there is adjustment for remoteness. There is adjustment depending of the type of program that they are delivering themselves or those who are delivered by Health Canada. So each case is unique. There was a formula developed years ago that takes into account population size, location, but over time we have added program based on capacity and...
Sorry, I have just one more question I need to ask, and that is, you mentioned earlier the Northwest Territories, Inuit and BC have all now started to take a greater control, self-determination, self-government over the health delivery. Have you done a comparison as to how the results are from this now occurring compared to other non-Indigenous service health delivery and Indigenous communities where they didn't have that self-determination?
It's too early in BC to measure the health outcome because the transfer have occurred in 2013, operationally. But we have seen evidence in self-governing arrangement, other part of the country where increased control have led to better result. Yes, but not in British Columbia at this time. It's too early.
Thank you, Chair, and thank you very much. I apologize for cutting you off so much, but I knew I had very, very small window.
Okay, well, thank you very much, Mr. Doige, Khan, Perron, and Wong, and Ms. Gillis. Thank you very much for your time and your words today. We know the work you do is very hard and that you work very hard to get it done. Thank you very much. We're going to take a short suspend, and then we'll reconvene in about 2 minutes. Thanks.